Hello, my name is Nick Testa, and over the next few minutes we're going to talk about what you can do to improve the care of the septic patient. Over 250,000 patients die in the United States every year of sepsis. At LAC-USC, over 1/3 of our mortality is a result of sepsis. This fact is so significant that in early 2010 we engaged in a contract with the federal government saying that we were going to decrease our sepsis mortality. This contract is frequently referred to as the 1115 waiver. And the federal government will pay us for our improved performance. But most importantly, through our improved performance, I will show you how we are going to save patients' lives. The classic approach to sepsis was defined by Manny Rivers through early goal-directed therapy. We have streamlined the early goal-directed therapy approach to remain being aggressive and identifying the septic patient early, but decreasing the interventions to just 4 critical interventions. Those 4 critical interventions are as follows. We need to get blood cultures on the patient before antibiotics. We need to draw lactate on the patient. We need to give the patient a fluid bolus of 20 cc's per kg, and we need to initiate antibiotics. In the emergency department, we've set an aggressive time of within 3 hours of that patient declaring sepsis. And on the inpatient unit, we've narrowed it down to just 1 hour. We want to be able to initiate blood antibiotics for that patient. So let's look at a little data for what we've seen to date. If we look back to 2009, we see the red bar is our mortality. We see that we had an over 44% mortality rate for our septic patients. If we look at that same period of time, we see the green bar at 28% is our compliance with those 4 critical elements. As we move forward in time, we look to our most recent data, and we see our bundle compliance is up to 67%, and our mortality is now down to 23%. We've seen a steady decrease of 21% in our mortality from sepsis, thanks to the implementation of this bundle. But we are not done yet. So let's look at a little bit more specific data regarding our patients. We see that consistently 70% of our septic patients present through the emergency department. And then a smaller yet important group declare sepsis once they are in-house. This is about 30% of our patient population. In the emergency department, we've been focusing on sepsis for a little bit longer, and we've seen a better response with our compliance with the 4 critical elements of the bundle. We steadily now are between 70 and 80% compliance in the ED. But if we look to our inpatient units, we see a different story. The inpatient units, we hover between 10 and 25% compliance. Our most recent quarter, as we've started initiating more activities and more focus on the inpatient unit, we see a jump up to 53%. But there is still a lot of work to be done with our patients who become septic in the inpatient unit or the ICUs. So the rest of this presentation is going to be engaging you in what you can do to make sure that our patients are identified early and treated aggressively. We've created a simple algorithm that involves both nursing and physicians. And the critical element to this algorithm is that it is a nursing and physician project. This will fail if we rely on just nurses or just physicians. We need to work together as a team. So the first portion of this algorithm involves our nursing colleagues. So let's talk first about what we need our nurses to do. Our nurses need to be vigilant for the potentially septic patient. They need to identify, and then they need to notify. So let's talk about what they're going to identify. We want them to look for the following vital signs and laboratory values to trigger our sepsis protocol. That includes an elevated respiratory rate, greater than 20, tachycardia greater than 90, temperature of 100.4 or above, a WBC count of 12 or less than 4, a systolic blood count or a systolic blood pressure below 90, and if any of those 2 elements are present in the suspected environment of a patient who we think is infected, we want the nurse to call the physician and notify. And when they notify the physician, we want them to tell them what they're thinking. We think this patient is septic. And then it gets handed over to the physician's responsibility. And this is what we want our doctors to do. So we want our physicians to initiate the orders and then go see the patient. So what do we mean by this? Let's look more specifically. We've created an order protocol that allows the physician to give a verbal order to start the sepsis protocol so that the nurse can start the blood cultures, draw the lactate, give a bolus, and start those antibiotics while the physician is coming to see the patient. Once those antibiotics and all those interventions are initiated, then the physician needs to assess the patient. And we know that sometimes that patient won't be septic or won't go on to develop full-blown sepsis, and that's okay. We want to throw the net widely and catch as many of these patients as possible, with the understanding that sometimes you'll get to the bedside and say, this is not sepsis, this patient was not infected, stop the orders, and that is okay. So to reiterate what those critical elements of the bundle are, they include blood cultures, lactate, fluid resuscitation, and initiating those antibiotics. With the caveat that in the ED, the antibiotics need to be initiated in the first 3 hours. And in the wards, those antibiotics need to be initiated within the first hour of identifying sepsis. So let's look at some of the tools we've developed more specifically. This is the sepsis order form. And you'll see on the top all your labs that you can order that you would want in a septic patient, with the serum lactate and the blood cultures being emphasized. Next, you see your fluid resuscitation orders. Now, to the right of that, you'll see that there is a box to check if you do not want to give the patient fluids. There may be a time where it is inappropriate to give a patient a fluid bolus. We just need you to document that you think it's inappropriate and we still are doing the right thing. And then you get your antibiotic selections. What's important to recognize with the antibiotic selections is if you use this form, the antibiotics do not require ID approval. At the bottom of the form, you'll see the one critical element, which is that this can be given as a verbal order to our nurses. It does require you to come back and see the patient, assess them, and sign off on the verbal order, but we don't want your presence at the bedside to delay the initiation of these critical, life-saving interventions. Thank you very much for allowing me to take a few minutes of your time to talk about sepsis. If you have any further questions, please don't hesitate to contact me. This is an ongoing process, and we know that we can continue to do better, but we can't do that without your continued support and input.